of the Reach Out and Read web series. Our topic today is Introduction to Early Relational Health, context of Reach Out and Read. And we have two amazing presenters. We have Dr. David Willis. We're honored to have Dr. Willis join us today as he brings decades of experience as a clinician, a child health system transformation trailblazer, and national early childhood and home visiting policy leader at HRSA. He currently works at the Center for the Study of Social Policy as a senior fellow to advance early relational health in child health systems and early childhood systems transformation. His long-standing focus on the coordination between pediatrics and early childhood communities to advance healthy child development makes him the ideal co-host of these weekly webinars. Thank you, Dave, for joining us. Dr. Catherine Clayton is our current medical director at Reach Out in Oregon and is a practicing pediatrician at Kaiser Gateway Medical Office. During her residency at OHSU, Dr. Clayton was introduced to Reach Out and Read and became an early champion of the White program and has been instrumental in expanding its reach within the Northwest Permanente Health. Dr. Clayton is also passionate about early child health and values the power that a book has to turn something unsettling into a positive experience. She has seen within her own family, as well as the family she serves, how even a few pages and a few minutes of snuggling can reset a mood and diminish stress. We're incredibly grateful to have her on our team and for the time and expertise she donates to the program. So now on to Dr. Clayton.
Thank you, Samira, and thank you everyone so much for joining us. I'm excited. So as a general pediatrician, my Reach Out and Read practice is one of the most joyful parts of my day, as I'm sure a lot of you can echo. Over the last year of getting a little more involved through this medical director position, I've realized that Reach Out and Read is so much more than just a joyful literacy promotion program, early literacy promotion, though it's that as well, and it is very joyful. It's a really powerful tool, I've realized, to promote early positive experiences and strengthen child caregiver relationships, which is really important right now during this time when people are home and they're not in contact with as many other caregivers. So for this reason, I'm super excited to have Dr. Willis here to talk about this really powerful work in early relational health. And I'm really hoping that it helps all of you reinvigorate your own Reach Out and Read practices as well as it has for me. So take it away, Dr. Willis.
Thanks, Kate, and thanks, Samira, for the amazing welcome. And I'm thrilled to bring to you today the discussion of the work that's been going on since I left Oregon. Many of you know I was in Oregon for 35 years as a clinician. I worked through the Oregon Pediatric Society, and we were working on that time about how does one build the well-being of all children. I'm a child development specialist by training, and thereby always been focused on how do you create the well-being of all children. We know what to do, but we're often not able to see that that occurs. And so today I'm going to share with you sort of the journey to relational health and where that work's come to be, all of which is the focus on building well-being of all kids. My goal, of course, for our learning objectives today, or to my strong belief, as you do, as to the power of Reach Out and Read to advance not only well-being, but also relational health. Secondly, I want to talk about some of the evidence-based practices that surround your good work. And then I'm hopeful that you leave this webinar with, if you haven't already, that current mindset shift that says foundational relationships build health, development, and future well-being. And so that's kind of the journey we're going to be on. I'm a pediatrician, still now a pediatrician, then was trained in infant mental health. And strikingly, we all know that the brain's development happens only through relationships and starts incredibly early. And by those first 1,000 days, so much of the foundations of who a child becomes in terms of not only their health status, stress regulation system, social emotional development, but also their readiness for school, their future social engagement, and their participation in social communities, and their own future gets defined so rapidly by the relationships experiences around them. And we know all of that, and yet all of us continue to be stunned, even prior to COVID, as to the challenges we face of our young children across the nation. And noting the last 3 points, the degree to which mental health disturbances develop in our young children is shocking. Those are, I would suggest to you, social emotional weaknesses, if not the impact of stress or neglect or poor relational experiences. Increasingly, we're aware that a significant percentage of kids come to school without quote unquote social emotional well-being and skills. That means something's not going well in those early years. And again, if we're thinking about our role as pediatricians in building the foundations for health, development, and well-being, it starts so early. Then some of the targets of looking at the processes early becomes a preventative mental health strategy, becomes a kindergarten readiness strategy. And I think all of us, have to embrace the fact that there's such great urgency now, especially in face of COVID and these moment in times. On a positive note, just last week, 0 to 3 put out its State of Baby's Yearbook 2020. Oregon comes out in the top quartile of all states in terms of some of the measurements of the well-being of babies. I'm highlighting that note that 40% of babies, parents report that they're reading to their baby every day. Although that's a big number that keeps us in the upper sector of the states, it's low in terms of population-based efforts. Similarly, we've been working 10 years on developmental screening rates, and even in Oregon, who defines the top of the percentage of developmental screening by primary care physicians, it's still only 60%. So although we can be proud of what we're doing, there's so much more that we can do in terms of our work moving forward. Now, this moment in time of hitting us with the COVID we all know the families and the challenges that families are experiencing. I'm sure you see it every day in your practice. Our colleagues at the University of Oregon, Phil Fisher at the Center for the Translational Neuroscience, they've been doing polling of a large group of parents just to monitor early childhood parent experiences. And 33% of caregivers were reporting that their young children are showing stress and reactions and fussiness. Caregivers themselves, more than 2/3 are reporting high degree of stress, as well as many are having a decrease of economic security. All of those stressors are dramatic in terms of how they begin to shape the experiences in families' home, and also bring challenges to us as to how do we as primary care physicians help prevent what people are unfortunately talking about as a future mental health crisis that may follow all of this. How do we not let this good crisis go to waste in terms of thinking about how do we help families focus on how they can protect their young children from the stress, as well as what can they be doing daily that can help this moment of time and this moment of challenge. I want to take you through a few trends as to what's important that people are thinking about. The science that defines how does one build healthy child development is well defined, and increasingly, since the original Neuron Neighborhood Report 12 years ago now, most recent reports are all talking about development is best driven in the context of relationships that are nurturing, positive, and stimulating, and how that builds a future well-being for the community. One of the trends that's really interesting in the moment is the recognition that poverty really matters. Poverty and racism are intertwined, but because of this COVID moment, there is discussions going on at many levels about what do we do about the poverties that has been driven in this moment in time. There are conversations going on about universal basic income or child allowance or guaranteed minimum income. These are happening actually in Congress. People are aware that the economic push from this COVID moment is really significant. We also have that second crisis, shall we say, or opportunity of taking an anti-racist frame from the standpoint of equity. It becomes really essential that we think about how do we create the relationship environments and the positive experiences for all children and counter any racist efforts that disrupt development. The other trend is to recognize that there's far more than the concept of trauma in terms of promoting first well-being, future well-being. There's an increasing recognition that the positive experiences around young children actually mitigate against adverse childhood experiences. And Oregon's been a champion in terms of leading about how adverse childhood experiences can be addressed intentionally by conversations with parents. But also we're learning that positive experiences that families experienced when they were young actually mitigate the impact of ACEs. So when we start talking about doing ACE screening with families, we may simultaneously want to be talking to them about what were their positive childhood experiences also, because it's those positive experiences that will mitigate the negative effects of ACEs. All of this is calling out the criticalness of relationships. The whole science of child development focuses that relationships are what drive outcomes. The whole work about trauma-informed systems effort is about using relationships for protection and for healing. And we've known this for decades. But how do we start to shape the use of and the strengthening of relationships towards building well-being? So about 10 years ago, when a number of us were involved with the American Academy's Early Brain and Child Development, the task force on early brain and child development, we were actively dialoguing about how does one strengthen relationships. And actually, Colleen Kraft commented that relationships are the new vital sign in pediatrics. And at that table was a dialogue that said, well, you know, early relational health is equally important as physical health and cognitive health. And that began to stick. This sense that not only are we focused on building cognitive and literacy and pre-kindergarten skills and of health, but we need to be attentive to strengthening the foundational relationships that build lifelong health. And when I was at HRSA, much of our discussion was about the health foundations for early learning. So those of you, all of us in Reach Out and Read, we're all focused, of course, on promoting, you know, the foundations for literacy, but that occurs in a relational experience. And I would propose to you, and we know that it starts incredibly early. So when we talk about early relational health, we're not actually talking about a new field. We're talking about an intentionality of bringing the science that we know about into action. It's operationalizing what we learned from the fields of infant mental health that's been in child psychology, that's been, you know, 25 to 40 years of work, and moving it into a prevention promotion strategy with those of us in pediatrics that touch the lives of basically all young children and families. There is no other structure in the nation that partners with families at the very start of those lives, and where the well-being of a child and family is in the center of the way we think about what our role is to help promote the well-being of children through the relationships of their families and their efforts. So people often ask, so what does early relational health look like? You may see this.
Wow.
So do any of you doubt that you're witness to the power of the relational experience between these two wonderful people? And we all know from child development that the building of that dear baby's brain is through the positive, stimulating, affective, and interactive experiences with others. The brain of young babies doesn't develop without their relationships themselves. So we're witnesses, pediatricians, to that beauty of a relational context. That's one example of relational health. Let me give you another. Some of you may have remembered seeing this.
They need to work on that, right? Yes. Did you understand it though? No. Okay. Oh, no, not this one. This is again now. Yeah, this last one.
I'm going to pause it for a second because it's delightful to watch. And as I see your faces, you're all smiling. And this went viral to over 1 million some people. And the fact that as an African-American man, father, and the beauty of this young boy was only one part of the story. The other part of the story is to what are you witnessing? And can you observe what it is that we objectively watching this interaction, what are the observable skills that you would say are healthy, positive, and promoting? And if you think developmentally, you may start seeing a number of elements that we as clinicians are witness to every day in your practices and of those around. So let's watch.
That's what I was wondering. I don't know what they're going to do next season because they did some stuff this time.
Okay, first you're seeing imitative efforts. Secondly, you're seeing initiation that's bidirectional and dyadic. So that little toddler points and then father responds. Father responds and the baby responds. And so you have this dyadic serve and return that good old Jack Sharkoff talks about. But there's also positive affect. There's also an equality of the pacing between one and the other. There's also imitative gesturing. There's also vocal imitation. So there are multiple observations that one can see that defines.
Oh, yeah. Right, don't bring that in. You know what I'm saying? Don't be saying stuff. You know what I'm saying? Yeah, I think that. Yeah. Like go somewhere else with that, but don't.
So, as much as that's wonderful to watch, many years ago, a number of us began to say, okay, what defines a strong relationship pattern? What are the characteristics? Let's become good physicians with our observational skills to start defining the elements of strong relational patterns, right? Because you and I know they're sequential, you and I know they develop. So there's a whole natural sequence of the skills that develop dyadically. So when one is looking at an interactive space, you can watch the development of the sequences of development that are between them. So at first there's that mutual attention and engagement, and then there's a mutual responsiveness that's dyadic, and a positive affective state that's really the driver. Affect drives human development. But then there's a pacing between them. As you watch that father and his young toddler, there was an equal pacing. One would initiate, and then the other would respond, the other would initiate, and the other member of the dyad would respond. There becomes some imitative functions that we start seeing around 8 months and 9 months of age, and then they start having a purpose together. My point is you can watch the sequence of social emotional development in front of you. That's the space of relational health. We as pediatricians have the privilege of being there and watching and seeing. We react to it ourselves, we resonate with it. We either are delighted by it, or we may well say to ourselves, I've got to be thinking about what I'm seeing and explore that further. The other part of the relational health framing is the science about synchrony and dyadic neurodevelopment is compelling. When one digs into the neuroscience work that looks at how the baby and the caregiver's brains and bodies become in synchrony as part of the developmental service, every system of the physiology becomes synchronous in work. So everywhere from what you can observe that by behaviorally, like we just did, to that you can see in all that micro dissection of parent-child interactions, micro-coding. You can see the dance that goes on that's very subtle. But if you look at physiological measures, when a young child and a family are attuned, there's actually a coupling of the heart rate synchrony and the affective regulation state. There's synchrony of some of the endocrinological systems and the dyadic patterns, And EEG patterns show synchrony often when there's eye-to-eye contact in the way that the brain systems become synchronous in the way they operate. My point is the physiology is designed to build the well-being through the relational space. So we've begun to define some of the principles of this framework of early relational health. One, it's based upon the criticalness of foundational relationship. All of this arises from listening to families and communities and the stories where they tell you about the strength of resiliency and about the strength in their communities. It really is the essence of building future health, early learning, social emotional well-being. It really is deeply science-based, it's family-centric, and it's also bi-directional to the delight of the parents and the children. So a good relational health pattern happens between people, and the adult caregivers experience the benefit as much as the child does, and yet it serves the child development. But we're very conscious that that this relational health frame has to value all human dignity and all races. And we've got to be deeply opposed to structural racism that disrupts that healthy pattern. We also recognize that it's not all about future development relationally, does have a context that matters. Poverty, racism, unsafe communities disrupt the relational experience. And so we can't just say, if we're focusing on relational health, that it's only the caregiver and the child as the driver of outcome. That relationship's in the context of others. It's in the context of the community. It's in the context of acceptability, or it's in the context of a social emotional environment. So those contexts become really important. And early relational health is foundational for later recovery, resiliency, and protection. But this is not about a program per se. It's actually an all-in strategy, so that more around not only we as a health sector recognizing and calling out the importance of early relational work, but we have to have partners in our community and our communication strategies that focus in the same way. We would say that it's a paradigm shift. We've been fortunate at the CSSP. After I left HRSA, we moved back here to the Northwest, but I've had the privilege of working at HRSA to advance this work. And we conducted a national survey about what do people already know about early relational health, and also what's going on out there. And we had almost 600 people that responded to the survey. The website noted here, you can see the survey if you're interested in reading it. But what was striking is about 65% of the early childhood system understood what the concept of early relational health was about. The sector of early childhood, health sector, and community does have a sense that relationships matter. We also, in our survey, asked people to describe what relational activities are already going on that can be in support of strengthening strong relationships. So you all know about home visiting, and then parent education approaches, early childhood systems work. But there was a strong shout out by these 600 people that responded to the survey nationally about Reach Out and Read, who was one of the top noted beyond health sector recognitions about service programs that promote foundational relationships within the medical home. What was also called out was promoting first relationships, the work about healthy steps, video interaction project, circle of security. These are variations of efforts that are committed to promoting and strengthening early relational health. So our survey, we learned a number of things from the survey. One is there's broad interest in this relational space. Secondly, many stakeholders, be that early care and education, parents, early childhood policy leaders, public health leaders, as well as physicians, recognize about how do we translate this relational health frame into action and to practices. There's a broad recognition of financing needs, of course, and policy needs. And there was a dialogue within the survey. Let's be very careful about how we define it so that we're not trying to create another way in which families can fail, but we want to be strength-based. We want to be promoting, and we want to advance an anti-racist frame within this view. So we also were able to engage the Frameworks Institute in a framing study and analysis about how best to communicate the importance of relational health and so people can understand it. And I don't know if you're familiar with the Frameworks Institute, but they were the communication organization that gave to Jack Shankar toxic stress as a driver for understanding the message about trauma. And so the languaging that one uses, the framing of communication really matters. So it's not just what you say, it's how you say it. To really have people understand what we mean by relational health and early relational health, it's how do we best say it? And framing when it's clear becomes a way to change public thinking. And they found that it's really important to start thinking beyond that. Foundational relationships really matter, but it's not just about parents, and it's not just about the family bubble. It's also about the communities and the supports around strengthening relationships. If we're going to move a national agenda about the importance of relationships, we have to place that into a context that people can understand. So the framework study, and that's also on our website, found sort of three major elements. One, when we talk about early childhood and early relational health, we have to talk about early, because the public understands early childhood as being being preschool and above. The relational needs of infants and toddlers, the public doesn't think much about. It's almost a blind spot. Secondly, they found that the term, beyond the health system understands early relational health as a framing that makes perfect sense to us. But when you go to parents and you go to early care and education providers and to the public, the term foundational relationships have more power as a framing upon which why this work matters. The other thing they discovered was that caregiver experience around strong relationships is very important, and that the joy and the gratification of the foundational relationships in the moment is really important. So when one thinks about early relational health and in communication with families, it's not just about the utility of that to build the well-being of a child, but there's joy that comes back to the caregiver themselves, such that those are in the moment experiences that are really meaningful. Just like Kate talked about reading with her young ones. Just like all of us know that when we sit down with our young children and we have the moment in time of reading and communicating, those are magical moments that serve not only us as adults and caregivers, but also are meaningful for a child. So why am I talking about all of this? Well, I believe that Reach Out and Read is one of the major strategies that we can bring to bear to strengthen and promote a relational frame where we can touch the largest number of children. And as child health systems are rapidly in transition and transformation, be that the telemedicine approach that's occurring, be that the coordination of team-based care with expanded models, we already have a vast number of you and others that recognize that promoting the foundations for literacy by a book reading and an experience is a way to open up dialogues about the relationship patterns. Secondly, what we've witnessed, as some of you are probably doing virtual well child visits, you're in the center of watching relationship patterns. You can see the relational patterns in front of you. And hence, the growing interest is thinking about how do we advance early relational health within a Reach Out and Read frame. And I'm incredibly fortunate to be connected also nationally. And you may be aware the Next Chapter Summit that was held back in November by the National Reach Out and Read and the thought leaders actually focused on a relational health frame within future thinking for Reach Out and Read. In fact, their next chapter strategic roadmap includes the concept of promoting foundational relationship work. And within that sense of longer term outcomes for where Reach Out and Read may be heading in terms of what's moving forward is in fact the promotion of this foundational relationship work. So there's increasing interest about how we as Reach on Read leaders can move this work forward. Now, I mean, as just to take that moment and spend a moment, what you may see clinically in your practice is, I have a few videos. Bob Needleman, who's one of the founders of Reach on Read, shared with me a few ways of thinking about relational health and what you're observing in the book giving moment in Reach on Read visits. So let's look for a moment here.
Go for it.
And I want you to think about what are you observing relationally? And what are the skills that you're observing in the moment that would have you say this dyadic pattern is strong? Or how would you make a decision about what you might say in the support and the promotion of the relational health of this cute little dyad?
Give me a smile.
Okay, a few things I see, and I'm thinking each one of you are probably ticking through your own mind what you're observing. But first, there's positive affect. That's really important. The driver of human development is positive affect. If that's missing, you may have screened it by maternal depression, but you want to be seeing it happening. The second is you want to see that there's some support of the gesturing and learning, and it's subtle, but it's present. This little baby is recognizing, mother's responding, there's some initiation between them, and she's supporting this little baby's learning and observation in the moment. And you might find yourself saying, every time this little baby, every time your little girl makes a comment, answer it with a comment. Start trying to teaching the dyadic process, because you know how powerful that is about contingency. You may have your own thoughts about what you might say in promoting the relational health of that moment in time. Let's look at another. Similarly, thanks to Bob Needleman.
Damn.
Now, is anybody worried? And think about how rapidly you witnessed that this little dyadic pattern is struggling. Now, one might say, is this just one example and are they fine? But what you witnessed was the disengagement cues, a lack of affect, the difficulty connecting and holding on to each other in terms of turn taking. So something's going on dyadically, but you're looking at the moment of a relational health observation, which might challenge you then to think about what your next actions will be. So just a few tips from this foundational relationship view. You may ask directly with your families about what are you and your baby discovering about each other? You always want to encourage parents to connect to someone else, because parents in isolation is not good for them. That sense of connecting at this moment of COVID. Routines really matter. You know all of that. You may also know the power of connecting, like we call it 30 hugs a day. And that is the more you give physical connection during the day actually promotes toddlers' health. Reading together, of course, are incredibly powerful moments of connection. And of course, we always want to support parents, knowing that there are moments of good and bad every day. All of this is founded on the sense of the power of human connections. And Fred Rogers, the Fred Rogers Institute is a part of our earlier learning early relational health work. And recently they shared with us 3 comments that come out of his kind of thinking. And every one human relationship can help us weather adversity and protect anyone from harm. The power of human relationships comes from simple and ordinary daily interactions, and none of us need to be perfect. Those kind of messages to parents likewise have power in the support of a relational context. So I wanted to share with you just this sort of overview of what we're talking about in a relational health sphere. I wanted to challenge you to think about how do you as relational health champions think about how this mindset can be meaningful. And so I welcome the dialogue, and Kate, may I turn it back to you?
All right, so it doesn't look like there's any questions in the chat. I may real quick, if anyone has any specific questions, open that up. But I also just wanted to share a couple of my experiences since sort of hearing about this early relational health framing and positive childhood experiences and first relationships. I had this wonderful time at my clinic where we were only seeing the well babies between newborn to 2 years. And so I feel like I had this intense, you know, it'd be like 10 per half session of just relationships, one after another after another. And I definitely found myself incorporating a lot of the language that Dr. Willis is using as I give the book, or even because at Kaiser we don't give books until 6 months, even those earlier visits when I would see the parent having that dyadic interaction with the baby, you know, really praising that and showing my own joy that I'm seeing that. Because I think we all need to be reminded, you know, even as physicians who know that's important, you know, it can help all of us to be reminded about how beautiful and healing and powerful that is, you know, for a child when you see a really exceptional relationship. And then when there was some struggling, you know, I would try to model, you know, do the best that I could, and every family's different, obviously, you know, but model that. And often I would see the parents start to smile as the baby started interacting with me in that serve and return manner. So that was some of the ways in which I feel like this framing of early relational health has really brought my reach out and read practice into sort of the forefront. It's more than just like, you should read with your kid, you know, but this is really a strengthening for their brain and for your relationship. So I'm curious if, you know, anyone has any comments about that or questions. It looks like, so Jonathan Russell, I don't know where you're from, but it says, I really appreciate the framing of early relational health as it relates to reach out and read and some of the ideas shared in discussing relationships with families. Yeah, I agree. I think though that slide with kind of things to discuss can be really powerful in keeping the sort of frame of early relationships positive for families. From Winston, Oregon. Thank you, Jonathan. Well, we could, the next sort of question that I was thinking, we can kind of move on to that one if there aren't any other comments or questions. I was sort of curious, you know, a lot of clinics in Oregon don't start giving books until 6 months. And, you know, at Northwest Permanente, Kaiser, we're also, you know, guilty of that. Our program doesn't start until 6 months. So I'm curious if any of you are giving out books earlier. If not, how do you think, and do you think it would be helpful? And if there's anything that we can do, you know, to help promote that process of starting books a little bit earlier as a tool for early relationships.
And participants are welcome to unmute yourselves, are not just limited to the chat box as well. So feel free to chime in.
Well, yeah, I mean, oh, here we go. We have some more stuff coming up here.
One is from me, and it's just saying that we do have some donated books available that are meant to give out at the 2-week or 2-month well visit. And we do have cases available. So I left information in the chat box. If anybody is interested, they can contact me about those directly.
Awesome. Thank you so much, Kristen.
We have a study going on right now in Oregon with focus group with parents, both rural parents, African-American families, and then Latinx families, about how we as physicians can be supportive of their earliest relational experiences with their young children. So we are wanting to help parents be in the lead of how what this means to them. And early, before 6 months of age, all families are thinking about themselves with their babies, and they're getting used to a new experience. And I'm really curious, it's how you might think you would have a conversation with families about their moments with what are they discovering with their babies, or what's the relationship like now as becoming a new parent, or what's your history of experience with when you're growing up, and how might you think about how that impacts you currently in your current parenting experience, or like R.J. Gillespie has been sort of championing that, identifying the ACE history of families as well as their positive experiences in growing up, such that one can begin to have the dialogues about strengthening the current relationship ever more for the strength and moving future. There's a lot here that I think individually, all of you probably already do in your own practices in your own way. We're trying to think about how do we bring that ever more forward and champion that kind of work in a relational health frame.
Yeah, I agree, David. One of the things that I got really excited about with Reach Out and Read was when we had our ACEs training at Kaiser and started screening for ACEs, that I was sort of overwhelmed by the tools to build resiliency, until I realized that Reach Out and Read, at least for the younger ages, is one of those tools that builds resiliency and a positive experience to help to counteract, like you were saying in your slides, those ACEs.
There's been increasing interest of pairing an ACE screen with a PCE, the Positive Childhood Experience screen, so that one's very intentional about focusing on the resiliency side of the relationships despite adversity, all for the benefit of now their child and the development moving forward, plus the dialogues that you could be having with families about that area in terms of promoting well-being.
Mm-hmm. And yeah, I did want to share too one more tool that I've been using, again, when all of the Kaiser pediatricians came together at one clinic to do well child checks. I learned some good practices from them. And for those visits, 2 weeks, 2 months, 4 months, where we didn't give books because we didn't have the funding, I was giving the ages and stages learning activities, which I also feel like are sort of this menu. Yes, they promote development, but a lot of them also promote dyadic relationships and positive experiences. And so that was my sort of tangible tool for those visits when we weren't giving books, to be able to say, hey, look at this. If you're in one of those slumps and you don't know what to do with your baby, try one of these activities. They may, really be fun for you. So that was another tool that I used.
Mm-hmm. Mm-hmm. I see in the chat a comment about one of the reasons it's harder to have books ready has to do with the financing of books. Mm-hmm. And I think, that's an ongoing challenge for every affiliate across the country. On the other hand, there's increasing curiosity by Medicaid organizations and others about school readiness being an outcome of the health sector's role. And the more we are champions as to how a relationally focused effort to reach out and read, the more we're visible about that, may allow, like what's happened with some supports in Oklahoma, where Medicaid's playing some role in helping to support the financing structures of Reach Out and Read. I think I think there's growth in this space as to problem solution making, such that we can bring books to become more available. So it's like, stay tuned.
Okay, well, thank you everyone so much for coming and listening. I'm really excited about this work and hope that you all would be able to join us for future calls with different topics, which may be a little in flux, but we'll keep you up to date about what those topics are. Please feel free to send us any questions, or if you want to connect about anything else, you can let any of the Reach Out and Read Oregon members know those questions.
Thanks, everybody.
Okay, thank you.
Thank you all.
Thank you, Dave. Thank you, Kate. Until
Bye-bye.
next time.
Coming. Bye.
And then staff will stay on for a few minutes.
Okay. How long did we take? What time is it now?
12:51.
Good.
Okay, I think it's just us.
Perfect.
I just had to manually remove everyone.
They just wanted to stay.
We had
I
50
already have 3 emails about those books. I
that's
realized
great.
I'm like, this is a golden opportunity to get rid of those 12 cases of books they just had delivered to Samira's garage.
Yeah. My husband was asking me about them yesterday. What's your plan for these 12 boxes that's sitting in the garage? I was like, just ignore them.
Well, you're,
Hey, Dave. Thank
That
you,
was
Kate.
wonderful.
Thank
Yeah,
you, Dave. It was great. I just could not help but think that I wish I had seen this presentation when my kids were younger. I felt I would be such a better parent, but I'm about 32 years late, but